Hello, everyone. My name is Shilpa Gaikwad, and it's my pleasure to invite our first speaker of the day, our own Dr. Whitney, who needs no introduction. Dr. Whitney will be talking about the advances in the management of PPPV. All yours, Dr. Whitney.
Thank you very much. I wanted to start out with a very interesting fact that I saw this morning from the Smithsonian. They took a half of a piece of rice, about that size, from a human brain, and this is what they found. It's over here. That in that half a piece of brain, the size of a half of a piece of rice, there were 57,000 cells and 150 million synapses, 150 million. So think about how complex the brain is and how complex all this information is, even with something as simple as what we used to think of related to BPPV. It's not nearly as simple as we all think. And I just wanted to comment that one of the things that I do have in common with some of you is that at least one of you, is that I love hockey. I can't play a ukulele. I don't speak Polish. I am a rotten photographer. I cannot do the high jump. I cannot do a backflip. And amazingly enough, I am not pregnant. So you guys have some amazing skills. So we're going to have some fun here for the next hour. All right. So what I'm going to talk about here is newer evidence related to BPPV examination and treatment. So if you take a look at this, usually when I show this, people are kind of looking at this and saying, what in tarnation is this? And it takes a while. And eventually somebody usually comes up with this. And if you look really closely right here, what you're looking at is a semicircular canal. And this is how old they are. So they were in T-Rex. So that is actually the semicircular canal there, right here, of a Tyrannosaurus Rex. And as I like to say, think about T-Rex falling over from BPPV. It would be pretty darn dramatic for him to fall over, but humans do fall over. There's really good evidence that fractures occur and frequent falls occur because of BPPV. So this is the basic diagram that I like so much by Kelly in this book. You've got your cochlea, you've got your semicircular canals, and most of the time we've always thought it was in the posterior canal, but I'm going to share with you some data that says maybe we've been wrong, and then it may not be quite as common in the posterior canal as we always thought. I always said that it was 90% in the posterior canal, 8% in the horizontal canal, 8 or 9, and maybe 1% in the anterior canal. But I'll show you the paper by Bhandari that might shake up your world a little bit, okay? I like to remind all of us that this is what the cupula actually looks like. It's often depicted as like a leaf shape, but it's really shaped like a sail that the wind kind of pushes against it. And this is what the cupula actually looks like in, I think this is in a squirrel monkey. All right, so that's what the cupula really looks like. And this is a very nice picture that Anita Bhandari has done. She and I are going to actually start a project, I think, soon. We had a conversation about 2 weeks ago. She's out of India, and I believe she's a neurologist. I'm almost positive. But her husband has a company that sells ENT equipment. All right. And what she's trying to show you here is that this is the long arm here. This is depicting the horizontal canal. And what she's saying is that it can be stuck, the debris can be stuck on the cupula on the long arm of the canal. It can be on the short arm here, stuck, or cupulolithiasis, and it can be free floating on the short arm within the longer arm. And there can also be some debris stuck and or sitting here in this aspect of the semicircular canal. I saw that somebody was from Belgium, so I thought that, and maybe the Netherlands. So I thought I put this in this morning after I looked at some of the slides describing who you all were. And this is in Copenhagen, and there are canals all over Copenhagen. And these little balls look like otoconia to Dr. Clendaniel, Dr. Schubert, and I. So we took a picture and used that in some of our talks. This is a human otoconia. Looks pretty amazing. And I don't know whether you guys can see, but these are some 3D images, these are made out of oops, I'm dropping my otoconia all over the place, but oh, lordy lord, don't touch your mouse there on accident. But these are otoconia here that I use with my patients. Hopefully you can kind of see those. And what I do is I try and explain that they've got a whole lot of otoconia and that the otoconia are no longer perfect. So this one would be a perfect otoconia. If you look at B here, in an older human, that's what you're looking at here, you can see that this otoconia here looks very different than this one. So this one looks to me pretty much like, this is from Walther's paper, what these actually look like in humans. And you can see the older person's otoconia don't look the same. So that's how I explain to people what's going on. And when I treat patients, although this is really, really small, I hope you can see it. This is the size of a real labyrinth. So the cochlea is, I don't know whether that would be on your right or your left, but that's the cochlea, and over here is your semicircular canals. And the whole system here is incredibly small. So I show this to my patients too, so that they understand how big the system is. I sometimes even show them this picture because they say, how many of my crystals are out? And I say, we don't know, but what we do know is that you've got a lot of them. And you may have some just floating around in your ear all the time and not have symptoms. I put this in because it gets a star because I thought it was so cool. That this is the first paper I've ever seen where they actually visualized in horizontal canal BPPV the otoconia with a 3D CT. So if your patient ever says, can they image the otoconia or the crystals? The answer is yes. I always tell them that they're probably never going to get a picture themselves in their lifetimes because it'll cost too much money. But have they been imaged? The answer is yes, they have. This is the paper that I alluded to a few minutes ago here by Bhandari, and this is actually her husband, Rajesh, who is an engineer, really nice guy. I've met him too. Posterior horizontal and semicircular canal prevalence. So he actually sells this equipment, or doesn't sell the equipment. He puts the equipment in hospitals across Asia, Southeast Asia, and Africa right now with his company. So they own the equipment, they own the technician or pay the technician who's in the hospital. The hospital provides the space. They send the data to physicians who analyze the data and come up with a potential diagnosis for the patient and send it back to the local hospital. And that's how they got 3,975 people. And they, like I said, they own the data, and they had confirmed BPPV by either a neurologist or a neurotologist. And this is what they found. 48% had posterior canal BPPV, horizontal canal 46%, anterior canal 0.7, which I think is probably right, and multi-canal involvement was 5%. So think about that. The take-home message here, and that's why the man is sitting here with his little question mark, is you better be checking the horizontal canal. All right. So make sure that you do the Dix-Hallpike and the roll test before you make the decision about how you're going to treat your patient, in order to figure out what's most symptomatic, if it's in the posterior and or the horizontal canal. So think about that. Season of the year may make a difference. We all see patients who come in seasonally. They come in the spring. At least I used to see this all the time when I worked in the North Hills of Pittsburgh. And Whitman and Balow suggest that season may affect their BPPV, and less exposure to the sun may be the reason. This was repeated in South America by Zumamaya, and he found the same thing in the Southern Hemisphere. Now, prevention. Every patient who walks in to see us says, how can I not get this again? I can't stand this. So this makes me so nervous, right? For those people, you might think about suggesting vitamin D and calcium supplementation. Zhang in 2020 did a reported in a randomized trial that vitamin D and calcium may actually decrease recurrence rates. So they got 518 people. They looked at annual recurrence rates. And what they did was this is what I share with my patients and tell them to check with their primary care physician and find out if they're willing to supplement. All right, if it's okay for them to take it. So the deal is vitamin D, 400 IUs, and 500 milligrams of calcium carbonate 2 times a day. All right, when the serum vitamin D was lower than 20 ng/ml. So the deal is that it really probably doesn't do a whole heck of a lot if your calcium levels and vitamin D levels are normal. But if they're lower than normal, then and you supplement it, there was a difference in recurrence rate of about 38% versus 47%. Now that's not huge, but if it might result in someone's getting a hip fracture and they're 90, that's huge, right? And even young people can have low vitamin D levels. So please don't think this is just for older people. There are a lot of younger, well, not, I shouldn't say a lot, but there are certainly young people that I have seen that had low vitamin D levels because they don't go outside much. They work, they might work at night. If you do night work, you sleep during the day, you're not going to get much supplementation of vitamin D from the sun. So even age doesn't really necessarily protect you from low vitamin D because of your job, right? This is a meta-analysis done about 2 years ago here now to look at supplementation. And they included 5 trials with over 1,200 people. And they saw a significant preventative effect of the use of vitamin D. And what they did is they actually said they suggest vitamin D supplementation if you have frequent BPPV occurrences, but especially if you have low vitamin D levels. So they're saying in this systematic review and meta-analysis was that, even if it comes frequently, just have them take the vitamin D anyway, it might help. So that's a thought, all right? Can't hurt as long as the physician says it's okay, their primary care physician. I was just out teaching with Michael Schubert out in Stanford, and we were at the local museum on the Stanford campus, and that looks like a Brant Daroff, right? Or a like the start of the Epley kind of maneuver, and that's a Rodin. And I've seen the same statue in Paris in the Louvre. So this is a pretty classic, cool picture. Most of us do the typical Dix Hall pike, but I've started to do the head over the pillow because it works so easily. And it's just as good as the standard Dix Hall pike. So instead of hanging somebody over the edge of something, over the edge of your table and then getting a little anxious that their head is hanging without support, I always put it on my leg or we have a table that bends down. But if you don't have that, or you work in hospitals or in home care, just put them over a pillow, but size matters. If the pillow is too high, they're going to go in too much extension. If the pillow is too low, you're not going to get that. You can get the 45 degrees of rotation, but you may not be able to get that 20 to 30 degrees of extension that you need for a typical Dix Hall pike. So the size of this pillow makes a difference, but it's really nice that you can do this just in the hospital bed and definitely in home care. And this hand, I'm not sure why it's ever there, but I never put anything on the front of people's faces or around their neck because they get extremely nervous. So I would not put your hand there. A newer trick, the loaded Dix Hall pike, all right? And this is a really, I use it all the time. So if I'm going to do the Dix Hall pike over the pillow or the Dix Hall pike in the standard fashion, what I do is I load it. And the duration of the loading Dix Hall pike in terms of the nystagmus was longer than the standard Dix Hall pike. And they also reported bigger symptoms, higher magnitude symptoms. And it was more sensitive. So let me show you what Luke and colleagues did. And this was done actually in Eastern Pennsylvania, this paper. So the duration of the standard Dixhall pike was 8 seconds. And when they loaded it, which I promised to show you in just a minute, was 12 and a half. And that might be enough if they keep especially if they keep their eyes closed, and they finally open them, you might then actually see the nystagmus. It's really hard to see nystagmus when the eyes are closed. And in terms of their severity of the symptoms, it's 3.8 out of 10 severity. And the loaded Dixhall pike, they actually said it was more intense. It's interesting. I taught this once, and somebody came up to me and said, I'm never going to do that because they get more symptoms and it lasts longer. So I'm not going to do it. And I'm like, what are you talking about? All you have to do is figure out whether they have it or not. You don't have to keep them there forever. And you know, the difference of 4 seconds to me is minuscule compared to knowing whether the patient has a right or a left positive Dixhall pike, you know, then I can treat them appropriately. I was really kind of surprised. I said, well, you know, it's not a big deal to me. I go for it. Right? I want to get the right thing. So here, what we're trying to show you here is the head flexion. So she's turned to the right for a right Dixhall pike, and then the head is tipped down 30 degrees. So you're tipping the head down. You're keeping it there for, they said 30 seconds, but everything's made up. So who knows how long you have to do it. But 30 seconds. Sometimes I'll keep it there a little longer if I want to make sure that I get the particles where I want them. And then you bring them back into the right Dixhall pike position. And they're doing it over the pillow like I just showed you. Take a look here. This is with the head flexed. So this is actually for the left Dixhall pike here. So she's flexed forward that 30 degrees. And what's happened is the debris, this is the debris and this is the cupula, all right? So the debris is right next to the cupula. And then when she lays down, it's moved this far, okay? Now this is your standard Dixhall pike here in C. The head is turned, but not flexed. See where the debris is? So the debris is not next to the cupula. So it has less room to actually travel when you do the Dixhall pike. See how this is a shorter excursion here as compared to here. And that's why the nystagmus lasts longer here, and you're probably more likely to get a positive Dixhall pike. If you decide, well, I still like the standard Dixhall pike, go for it. If you really believe they have it and you didn't get it the first time, then try the loaded Dixhall pike. And my guess is that you'll be more likely to actually see a positive Dixhall pike. This is a BPPV questionnaire that H.J. Kim came up with in 2020, and Jisoo Kim was part of this too. They're starting to use AI to make the diagnosis of BPPV. And there were 6 questions here. And they said based on these 6 questions, they could figure out not only did they have BPPV, but what type it was, and also which side it was. And I have a hard time believing it's as good as they said, but they reported that it helped identify that they had BPPV, which I completely agree. And they said that it assisted in determining the correct side, but I'm not so sure because I've had a ton of people that say, you know, I only spin when I turn to the left, but they have right posterior canal BPPV. So I'm not so sure about side, but can it help you figure out if they have BPPV? Absolutely. So the sensitivity was 87%, specificity 90%. So this is a neat little, these are some of the questions if you suspect that a person has BPPV that you could ask. Very valuable. Now, what they did was they went on in 2023 and published this in Neurology, where they used the questionnaire in people who had already had BPPV diagnosed by a physician. They sent them home with instructions about treatment, and 25% of the 585 people that they had included originally were excluded because of cognition. They couldn't remember, or they had multiple canal involvement. They said they didn't want to do it. They might have been afraid, but we don't know. We just know they declined. They had back problems, said they couldn't do it, or they didn't know how to use the internet. So even that's one of the things I talked about at the end yesterday with Dr. Klatt's question about where do I see things going. And these 25% here are people that are not going to be well served by telehealth or, kind of things over the phone or by a movie because they really can't do it themselves. They reported with intention to treat analysis, 85% were successfully treated with this web-based intervention with the movie that they sent them. And 43% were better in the control group. So just moving people around, I always say that there's a certain number of people who live with BPPV, they're going to get better no matter what we do. And what we have to start to figure out is who are the people who aren't going to get better without our intervention. So we don't spend healthcare dollars on people that it's going to resolve spontaneously because they move a lot, for example. Now, Jan came up with, in 2023, a different BPPV questionnaire. So there's a whole lot of BPPV questionnaires out there, but they all kind of coalesce under certain rules, and that is that the head or an object spins, although I'll tell you later they don't have to spin. The duration of symptoms is under a minute. The vertigo occurs when lying from supine or supine to sit or sitting to supine, sudden changes of position. It occurs when turning over in bed, and the symptoms disappear if you don't move the head. And they tested this questionnaire on 520 people with vertigo, and they identified 138 persons who had BPPV with a sensitivity of 92% and specificity of 88%. So again, these are some of the key questions to identify BPPV, because if you can't make the diagnosis, you can't fix the problem. Are we consistent when we do the EPLI? And the answer is not really. So this was an interesting study where they took 10 healthy people, took right-handed clinicians performing the EPLI, and they did the EPLI to the right and the left. And these were experienced folks. They recorded the angles of the head with a 3D or a 3-axis accelerometer. And they said there was a lot of variability in the angles, especially when you turn the head down, all right, to the floor. So if I'm doing the right Dix Hall Pike, here, so you go from head right to head left to nose down. It's the nose down position in several studies now that says that there's the greatest variability in terms of angles. So the mean error range for the various canals from 33 degrees, mean error ranged, okay, from 3 degrees for the left Dix Hall Pike to 18 degrees to the nose down. And it probably is important, the angle. So if you're off by a fair amount, you're probably not going to do an effective EPLI or SMONT or whatever other maneuver you decide to try. Now, the Lee maneuver is awesome. So the Lee maneuver here is where this is for posterior canal BPPV. And this is treating the right posterior canal BPPV. So you go down onto the involved side with no head movement, head stiff. They go down to the side. So if they've got a stiff back, stiff neck, it's great, or pain, you just bring them quickly over to the other side. So they stay 1 minute on this side, 2 minutes on this side. Well, I'm not sure about the numbers. Let me see if it's on this. No, it isn't here. It's done pretty rapidly, though, but basically I wait until the symptoms stop, take them to the other side, wait till the symptoms stop, plus a minute or two, and then bring them back up. And you can put their legs up on the table because that's not a comfortable position. Now, this is Dr. Lee doing it, and how he describes it is, how they describe it versus how they show it is always kind of different. So he sent me this from China, and he brings her whoosh down to, that's what I call a slam. So he's slamming her down to the right, onto the right ear, and then he brings her over to the left, which is actually not how it's described in the literature. And then he brings her up, because in the literature, they start in sitting. So people do it. That's his movie of how he does it. But I do it this way, and it works. This is the involved side. Have them lay down onto that side quickly. And then I quickly bring them to the other side, and then I set them up. So it works well. Now, short arm posterior canal BPV, remember I talked about that short arm business that can be on the long or the short arm on the other side of the cupula that we typically think of. And this paper is kind of an obscure paper, but in the Brazilian Journal of Otolaryngology, but they reported with this bow and yaw maneuver, they found a positive Dix-Hallpike in everybody, okay, in 171 people. Then they had them do this bow and yaw maneuver, and they all had a negative Dix-Hallpike after. And they're actually suggesting that the reason they had a negative Dix-Hallpike after is because it was on the short arm. So you can either, it says sit or kneel upright. I just have them sit. I have them bend as far, you probably have lost me, but as far down as they can go. And then you have them turn their head to the right and left. They don't even say how many times to turn the head. So in one place on YouTube, somebody crazily suggested you do it 60 times. I don't do anything 60 times, but the idea is to move the head rapidly, head down, and then you do the Dix-Hallpike again, and voila, it's gone. So we believe that this is a treatment for short arm posterior canal BPPV. Now, this paper came out about 6 weeks ago. I thought it was fascinating. There's some errors in the paper, so it's not perfect, but it's really kind of neat, because what they talk about, see all these little numbers? This is where the debris can be. All right, so if you look at 2, this is canalithiasis on the short arm. 4 is cupulolithiasis here on the short arm, because this is the short arm here. This is the yellow is the cupula. Then you've got 3 is debris stuck to the cupula. So it's cupulolithiasis, the long arm of the posterior canal here. Then you've got right here, this is kind of more free-floating canalithiasis. This is canalithiasis limited here to this periampular area of the long arm. And up here, this is kind of a problem here in the distal arm. And some people have called this sitting up vertigo if it's stuck up here. All right. And then they talk about what you would see. So this paper is actually worth pulling out and taking a look at it. It came out of Spain, and it's really nicely done. There's at least one or two errors in this table. So it's not perfect, but it's still really a nice review of where the debris can be. So if you think about it, years ago, when I first started learning about BPPV, we would say, oh, it's either stuck or it's loose in this long arm. Well, it's a lot more complex than that, and that's what we're finding. And I'm seeing many, many more people who are complex versus simple cases. So this is an example of something called type 2 BPPV. First paper that I saw that called type 2 BPPV came out in 2020. And this is where they report vertigo without nystagmus. So they're spinning with no nystagmus, but it's kind of special here. They have truncal retropulsion when sitting up. So when they come up, they do a whoa. Okay. 1/3 of 180 people met the above criteria. They reported longer symptom durations. So they have vertigo without nystagmus. They feel like they're going to fall over or fall forward when they come up. Usually it's backwards though. Had a long symptom duration, and they're suggesting the otoconia line up with the cupula during the Dix-Hallpike, and that's why this happens. But they do respond well to the canal through positioning maneuver, right? So this came out of some of the folks in the U.S. One was Mike Schubert, and then some people from Switzerland. It's a really well done study. Upon retesting of these 66 cases with this type 2 BPPV, 19 developed slight persistent positional downbeat nystagmus. And they said that might have been due to the otoconia entering the short arm of the posterior semicircular canal. And the reason they may not have had nystagmus is that the otoconia aligned with the gravitational pull of the cupula. And that's why it wasn't deflected. Kind of like when we talk about that with light cupula, it's the same idea. So this is kind of type 2 BPV or subjective BPV that others have picked up. This is by Jisoo Kim. They presented a case with eye movements. In this particular paper, it came out about 3 or 4 weeks ago. And what they talked about is here's the utricular side and here's the long arm side. And when you bring the person down into the Dix-Hallpike position, what actually happens is the debris actually is right next to the cupula, but there's no weight there. So there's no pull on it. So they don't feel much there. But when you bring them up a little bit, just a little bit here, what happens is, see the weight here of the otoconia on the cupula here actually is going to push down on it and cause them to have nystagmus. So this is one of the things that Jisoo Kim and other folks are actually talking about. So he's the senior author on this paper. Now, I just took this right from the paper, which is pretty pitiful, but I thought you might want to read it later. And what it does is it gives you hypotheses as to why this may be occurring. So I'm not going to take time to read this to you. You're fully capable of reading. But it gives you some theories like I just talked about. They're in writing here from the paper directly to give you some idea of what people were talking about related to why this might be occurring, all right? So again, what we were talking about is here, and there's this concept that Socio talks about sitting up vertigo. Some people talk about right here that this part of the canal may be really thin, very small, and you have to almost force the debris through here, through this part of the semicircular canal. So this is what Vannucci has talked about, and also Socio right here, that the debris can be in this area of the posterior canal. This is the anterior canal, posterior canal, and horizontal canal to orient you. And what will you do is, if you see this, this is when the nystagmus doesn't fatigue with repeated repositionings. It may be stuck here, all right? So this is the involved ear, the left ear right here. So you turn the nose 45 degrees towards the healthy side, and you bring them down, kind of slowly down, and a little bit quickly at the very, very end, all right, to try and get the debris in place. And then what you do is basically what you're trying to do, if the debris here, what you're trying to do is shove it down. So when you bring the head up, what you're actually trying to do, let's see if I can show it to you here. Posterior canal. What you're really trying to do is force it to go, sorry, I'll do it this way, force it to go towards the common crus here and then dump out. And so that's another possibility that Vannucci has talked about with trying the demi-semant for what he calls left apogeotrophic posterior canal semicircular canal BPPV. Okay. Now this one's got a lot of press. Actually, there's two papers. This one is from 2021, and then I think I have another slide from 2022. So this is the typical semant I know you all know how to do, right? So you turn the head away from the involved side. You bring them down over onto the bed. You bring them quickly onto the other side and sit them up. Now the Semant Plus has a little bit of a twist to it. So Michael Stroop came up with this and did a very nice randomized trial in Germany. I know there were some people in Belgium and the Netherlands collecting data for him, some physiotherapists. And so the head is turned to the left, to the right, excuse me, to treat posterior canal BPPV. But take a look at what he does. He brings her way down over the edge, and then he brings her back onto the table. So it's nose up here, nose down here, but it's all about the angles. So he's bringing her down further, okay? And when he brings her down further, you're kind of loading up the system, and then he tries to dump the debris out by bringing the nose down on the other side. And what this is the picture of it, and then I'll describe how I've modified it a little bit. So this is Professor Stroop here. He's treating right posterior canal BPPV, and I just modified because of his posture. All right, so it's nose up to nose down, and then he brings her up. Now I could move anybody probably like that on a table that low, but anybody bigger than her, I'm going to blow out my spine because she's very capable of doing it. So I raised the table up. I put a stool on the floor So the hand is, I do exactly what he does, just at different angles. So she comes down onto the stool with her right hand when she goes down. So let's just show you again. So when he brings her down, I have her hand on the stool. So my back is not bent as far as his is. And then I do the same thing, bringing her back over. And again, I'm not having to bend over as far. And then he brings her back up. So I haven't changed the maneuver at all from what Professor Stroop talks about. I just do it so that I don't get back pain. And the kick with this, here's the data from 2023. So this is a second randomized trial, all right? And they randomized him in versus, they did the SMONT Plus or the Epley, and the physician did one maneuver, and then they performed self-treatments at home 3 times a day in the morning, 3 at noon, and 3 in the evening. And that's not at all what I do, at least in my practice in the United States. I treat them. I want them to stay still for about 24 hours, not stay still, but not be too aggressive, at least for the rest of the day. And then the next day, do whatever they want to. I don't do repeated maneuvers at home. I'm afraid, especially doing this month plus, I'd be afraid they'd fall off the bed. So, and I don't like to be sued. So I probably won't be doing this. The endpoint, at least at home, the endpoint for his study was no positional vertigo for 3 days in a row. That's a win. The meantime, no positional vertigo was 2 days for the SMONT Plus versus 3.3 days in the Epley group. And 20% of the Epley group and 25% of the SMONT group experienced nausea. So that's no surprise that they can get nauseous doing this. So does it work? Is it work a little bit better than the Epley? Looks like it. I have not changed. I do the SMONT Plus when I'm stuck. I do the Epley all the time because it's easy. I don't hurt myself. With the SMONT Plus, there's just too much moving the body. And if you're going to do the SMONT Plus and it's a larger person, get somebody behind to help you, and then it's easy to do. But don't try and do it yourself if they're large and you're not. No matter what, it's a lot smarter if they're not a very, very small person to actually get some help doing this. That's what I advise anyway. Here's another one. I said to the group yesterday who attended the lunch thing that there are now over 30 repositioning maneuvers, over 30. Every time I turn around, there's another one that I find. This is a universal repositioning maneuver. It's similar to the GANS maneuver. So I wanted to show it to you. This one came out in 2023, late 2023. So here's the person sitting. The thing that is interesting about this one that came out of South America is that they say that it can treat horizontal canal canalithiasis and posterior canal canalithiasis on the right side, and it can, and it makes logical sense, and I'll show you why, but in just a minute. But if you look here, she comes down and she's supposed to have her head tipped 30 to 45 degrees in this position. So you got to have some neck motion to do this. But it's similar to the GANS maneuver because GANS lays the person on the table also instead of having them go off the table. So this works. And then they roll over to the other side and they're still kind of tipped over that 30 to 45 degrees. And then you sit them up. And this theoretically, and this is a simulation of what they did, this theoretically can definitely treat right posterior canal and right horizontal canal canalithiasis. Okay. Does the Brandt-Daroff work? And the answer to treat BPPV, this is a systematic review of randomized trials. And they said that the Brandt-Daroff does not significantly reduce symptoms in people with posterior canal BPPV compared to the Epley or SMONT. So don't be giving people the Brandt-Daroff exercise. The Epley and the SMONT are much better. Okay. Now let's talk just a little bit about horizontal canal BPPV. Over half of the people with horizontal canal BPPV showed horizontal nystagmus during the Dix-Hall pike. So you will see horizontal nystagmus during a Dix-Hall pike. That's a take-home message. Don't be surprised instead of seeing this, if you see this. All right, so this is just to remind you what it looks like. And you don't always see it. This is in Spanish. So those of you who are bilingual, some of you speak Spanish. You're seeing he actually, if you look carefully, he is the longitudinal supine test essentially. He's got a right beat there. Can you see the right beating nystagmus? It's beating towards the right. You have to do the roll test to interpret what all that means. Now, then what he's going to do is he's going to turn his head to the right in just a minute. So Daniel, he's saying, "Ooh, I'm spinning a little, right?" I'm turn the head, and you really don't see much of anything there. So we saw the right beat when he first came down. You don't really see it there. Okay. He's turned him to the right, and there's just not much happening, right? Almost nothing. I don't really see anything. And he's not super symptomatic on this side yet, all right? Now he's going to bring him back to the center, which is what you're supposed to do. And now he's going to turn him to the left. And then you're going to see the nystagmus. So take a look. Turns him to the left. Now look at that uppermost eye. That's cupulolithiasis. And it's really intense nystagmus there. It's beating towards the sky. It's not beating towards earth. Canalithiasis would be towards earth. So this guy's got cupulolithiasis very strong on the left. I'm going to stop the video because I don't have time to show you, but if we take him to the right, you'll eventually see that he's got cupulolithiasis on the right also, and it's less intense. So he actually has right cupulolithiasis, and he ended up doing very well. But I just want to remind you what it looks like. So interventions. This is the roll. Excuse me, let me see if I can get that in the right spot. There we go. So this is the roll maneuver here. And this is Dr. Bhandari's movie. The green is the cupula, the yellow is the debris. So this is when he turns the head to the right, the debris moves, brings the head up. This is how you do, for example, the barbecue maneuver, right? But bring the head to the left. So he's going to turn that way, see which way the nystagmus is worse. And actually, this is like the Lee Quick maneuver that actually fixes it right there. You may just be able to stop with the head to the left. You don't have to do any further than that. I'm going to show you that in just a minute. So she's just showing you that that's anatomically how they think this happens. Now the Gaffoni, a lot of us use the Gaffoni. This is for treating geotropic horizontal canal BPPV to the right. So take a look. So if it's on the right side, you go onto the non-involved side. So they're going to go down to the left. So this is your typical phony. Here's the debris here. He's going to bring him down. The debris moves. And then they're going to, excuse me, going to go nose down. And the debris dumps out the rest of the way. So this is your typical Gaffoni for right geotropic horizontal canal BPPV. I no longer do the barbecue spit maneuver. The Gaffoni meta-analysis shows that there's no difference between the Gaffoni and other maneuvers. It's better than a sham, and it has similar conversion rates. So the Gaffoni is a good maneuver to use. So I advocate you using that in the clinic. Now, this is one you may be less familiar with. This is the Lee Quick repositioning maneuver. Start for geotropic horizontal canal BPPV. You start them in supine. Right side's involved. They roll to the right side, stay there till the symptoms stop. Then they roll quickly to the left side, stay there for 2 minutes, and then you bring them up to sitting. So they roll to the right, they roll to the left, and they sit up, and it works. So there's no difference between the Lee and the barbecue maneuver at 1 day, 3 days, 1 week, and 1 month. And it takes less time than the barbecue, and it's a heck of a lot easier on the patient and a heck of a lot easier on you to do the Lee Quick or the Gaffoni maneuver, right? And this was a comparison of the Lee versus the Gaffoni that came out in 2021. And so there's no difference between the Lee and the Gaffoni, but it was retrospective. So it's like not as great. The other one was a prospective randomized trial. But still, there's at least some data in the literature that says that there's probably not a difference. And I'm sure there'll be an RCT that comes out to support that. Now, the anterior canal BPPV, I don't see very often. It's under 3% of the cases. You can treat with either an Epley or the Iacovino maneuver. This is the systematic review, the most recent one that came out for anterior canal. There's no evidence-based guidelines yet on it. It's not, I don't think it's even really mentioned in the BPPV guidelines from the American Academy of Head and Neck Surgery. And overall success rates are about 75%. So this is one of the maneuvers that you can do. This is the test that you can do to actually test to see if they have anterior canal BPPV. So you can do this supine head hanging, which is the test to figure out if they've got it. But you can also, it'll show up also in the typical Dix-Hall bike. All right. Now, here's a gentleman doing it.
I think it bothered me a bit. All right, so I'm gonna have you go ahead and lay
He's
back.
going to bring him back. Well, he just lays back over the pillow, over the roll, and take a look. And you don't see the torsion, but you definitely see the downbeat. And it does slowly fatigue over time. Just see it get better and better. So that is what I would definitely, and if you wanted to see the torsion, you have them look to the side. That's where the torsion will exhibit. Okay. So this is the Iacovino maneuver that you can try. That does work. I haven't seen too many anterior canals, but I have done the Iacovino maneuver. The debris is moving in this position. They're about 30. He describes a little further extension, but they actually did 30 here. So once it gets down into this position, then you're going to bring the head up about 45 degrees. That allows the debris to come down, and then it can fall in the posterior canal. You can definitely have a canal conversion because it doesn't always go that way. And then you try and bring them up and you hope that it falls. And if not, you've converted an anterior canal to a posterior canal BPPV, which is a heck of a lot easier to treat. Okay. And this is the modified Iacovino maneuver. So they're going to bring them down. Same thing that you just saw. And so they're going to bring the debris down to, and you have to wait. You know, I'm so impatient, but you really do have to wait till the debris stops moving, plus 20 to 30 seconds. Most people say 30 seconds now. All right, so be patient. And then you can just bring them up quickly. And the idea is that maybe just by moving it quickly, you may be able to get it to fall back through the common cruise there, if you're lucky. Okay. This is the Lee quick repositioning, or the Lee repositioning maneuver for anterior canal. This is pretty wild. You hang them over the edge of the table here. This is kind of over there's what do you call it? A wedge that she's kind of hanging over, and then you'll whip them head down, and you have to be small enough. You've got to be able enough. So very few of my patients are going to be able to pull that off. Now, the Tumarkin-like event we described in 2018 with posterior canal BPPV. When you bring people up, they have this where they feel like they're falling backwards. And what we found was that that 33 of these 221 people had this Tumarkin-like event when we did either the Epley or the Simon, which is about 15% of the people we saw. And all 33 were symptom-free when they saw this. So this is actually an indicator for successful intervention. So on the right here, what I'm saying is you must hold on to the patient when they come up, because these, if it hasn't happened to you yet, it will. We bring them up. Portuguese. Whoa. Oh my God. She's not happy at all. And if Nina was not holding on to her, what would happen is she could have easily fallen down onto the table. And you'll see that when she opens her eyes, she smiles, and we didn't kill her. She did get better, because all the people who experience that do actually get better. What's interesting is Kim et al. From South Korea actually repeated this and found almost exact 15% of his subjects had this falling back thing. All of them had a negative Dix-Hall pike when they were retested. And what he did, though, that we did not do, was he noted downbeating nystagmus. So maybe the downbeating nystagmus is driving this huge response. All right. That started at about 4 seconds and lasted for 20 seconds. And it's very interesting. So the numbers, our study is almost exactly matched, but he did it with goggles on and saw the downbeat. Take-home message of these two slides is that you can have people who say, oh, they have They have dizziness or vertigo triggered by a change of head position, but no nystagmus. So you put them down and they don't have any nystagmus, but it looks and sounds like BPPV. So you can have objective and subjective BPPV, and they do get better. So, but don't treat these people forever. This came out about 2 months ago by Metz. It's fascinating. They took people in the Falls Clinic, and there were 404 people who were on the wait list. They screened them with a 5-item DHI screening tool that Dr. Furman and I and Laura Morris developed years ago. And with that screening, 109 suggested of the 404 suggested they had BPPV, brought them in. Of those 109, 104 had BPPV. So it had 95% ability to detect that they had BPPV with our questions. And we don't know whether it decreases falls, because that's what you want to know, but it decreased their wait list by 25%. So these were the 5 questions that were in the paper that we published: the rolling in bed, supine to sit, looking up, quick head movements, and bending. And they scored an item as sometimes or always. It counted as 1. And if they got 3 or more points, they brought them in for exam. So you can, I mean, these are people who are falling. They've fallen. They have BPPV. And by decreasing their wait time, hopefully they prevented a future fall. So it's I think, a really cool study. So adults can have BPPV with no nystagmus, but it's a sensation of vertigo during the Dix-Hallpike. And adults can have visible nystagmus, but no reports of vertigo. And that's what you're going to hear Dr. Harrell talk a lot about in a few minutes later today. And when recognized, they get better. So you'd want to try to treat at least the subjective BPPV, but don't try forever. Okay. So just, I have 3 more minutes. So people do fall. I am going to, let me see here. I'm going to do this. Okay. So in 3 minutes, what I want to talk about, and I need to make that thing at the top go away now, since I was bad. Okay. That people fall with BPPV. We can decrease their dizziness, decrease their fear of falling, and improve their gait. So you can kind of read through some of these. Canal repositioning movers can reduce falls. That's in the literature by Jamani and Ganacha. So that's something that's important. And in the World's Falls Guidelines, Dr. Lee and I and others put together this commentary on the World Falls Guidelines because we think that they should be testing for BPPV in anybody who's fallen and anybody who has a balance problem over the age of 60. So that's what we put together related to some of the information that Dr. Harrell is going to talk to you about. So that paper we think was pretty key to try and get the idea that people need to be screened with a Dix-Hallpike to prevent falls. All right. And there's a 12-fold increase in the odds of falling among people with vestibular disorders who experience dizziness, and a 6-fold increase in the odds of falling in people with vestibular disorders who are asymptomatic. All right, let me just tell you that in terms of exercise dosing, after BPPV, people are doing exercise and trying to get people better. And it looks like in this particular study, more is better, just like I talked about yesterday. So this paper came out in 2024. Those who did more exercises, at least at 2 weeks, got better a little faster than the group who exercised less intensely. But the idea is that exercise intensity really may make a difference even in persons with residual dizziness after BPPV. And that residual dizziness is much more common in older people. This is a posterior canal systematic review that says that the Epley and the SMOT really work well, and that the SMOT was slightly better than the Epley at 1 month. In people under the age of 55, there's no difference. So the SMOT may actually have some benefits, but man, it's hard to physically do. So like I said, I don't usually do that one. I usually do the Epley. Recurrence rates from 2021 vary anywhere between 13% a year up to, I think it's up to 65, up to 65% 2 years out. So, but the people who get it most frequently are those with hyperlipidemia and hypertension, and diabetes. So those are the three major factors that Stafiansky reported in 2021. And pattern recurrence, I wanted to show you that 24% of the time when they come back, they have it in the same canal and the same type of BPPV. So what this is trying to show you by Kim et al. Is that if you tell them to do a right posterior canal, they came in and they had right posterior canal BPPV, and you say, this is how you fix it, the chance of them having right posterior canal BPPV the next time when they call you and you say, just do what we did before, is only 24%. So I'm very leery about telling people what to do based on not seeing them. I think that's kind of a dangerous thing to do. This is the paper I told you about, positional nystagmus in healthy people. There's 2 papers that have been published within the last year about this. And in an N of 78 people, young people, okay, mean age was 28 years, 71% had positional nystagmus in at least one position. And this is that TRV chair I said I'd show you yesterday. So normal people can have positional nystagmus. That's important to know. This is a great resource in our ophthalmology education library that's at the University of Utah for you to learn more about eye movements and BPPV. And this, I think I put in your thing, but I'm the vice president of the International Neurophysiotherapy Group, and we talk a lot and post a lot of articles about vestibular disorders that are current. So if you're interested, just get in your web browser on your phone and put in Input Connect, and it'll pop up. All right, and this is just a great site for teaching videos that you can use for teaching your colleagues. And I'm just going to flip through here. These are just a couple models that you can use, but this one's the best model in the world that I talked about yesterday from Japan. All right, so you have those slides, and we have 3 minutes for questions, and then I'll take questions at lunch too. I tried to make it for 10:45 or whatever. Sorry, I went 2 minutes over.
Thank you, Dr. Whitney, for a great talk. And you have a lot of questions, if you don't mind answering them. Okay, so I think there are a couple of questions, and the audience would love to know, like during assessment, is there a way to differentiate between short arm versus long arm BPPV?
Not really. So we don't know, and that's why what a lot of us write, not yet. That's why a lot of us do the bow and yaw to try and eliminate that, because we think if you do that pitch head forward and move the head to the right and left, you may actually be able to eliminate at least the canalithiasis concept of short arm posterior canal BPPV.
Thank you.
Mm-hmm.
See, the next question, there are multiple questions about vitamin D and the prevalence of BPPV.
Mm-hmm.
So what is your observation? Like, is there a correlation between prevalence of osteoporosis and BPPV? And how does vitamin D helps with the occurrence of BPPV?
Well, there's definitely a relationship between osteopenia and osteoporosis and BPPV, very solid in the literature. So if you can do anything to kind of strengthen the bones, because if you think about these otoconia, you know, they're made of calcium carbonate. So if you can supplement these and make these essentially stronger, then the next batch hopefully won't break off as easily. At least that's what we theorize happens with the otoconia.
Thank you. I think we have time for a couple of questions more. So there are some questions about what do you recommend, like what are the current recommendations for patients following the treatment? Like, do you recommend some specific sleeping positions, etc., when they go home?
Right, so I sort of follow the American Academy of Head and Neck Surgery's guidelines for BPPV, and they say don't do anything, but I add a little bit. So I don't do any collars, I don't do sitting up, sleeping semi-recline, nothing like that. But I tell people not to bend over for a couple hours, and don't go to sleep, and don't fall asleep in the chair. Wait to go to bed at night and sleep, and I don't care how they sleep. And that's because and actually Dr. Z does the same thing, David Z. And I do that because I've had too many people bend over to pick up their purse after I've finished and they get BPV again. They spin. So that's what I do. That's not what the guidelines say at all. Guidelines say to do nothing. I just think there isn't enough data for us to make a really good decision about that. So that's what I do, and it works fairly well. If I'm absolutely desperate, I might tell them to sleep in a special position, but we've had too many people come in with sores on their ears because somebody told them to sleep on one side and then they never moved from that side. So that's not a great idea. So literally they get pressure wounds on their ears. There are two papers. One is out in the literature and one that I reviewed that says that sleeping on one side could potentially cause it. And that does make sense. So if people can sleep on either side, that might be better than just sleeping on one side, but you can't tell people how to sleep, you know? So,
True.
yeah.
Thank you so much.
You're welcome.
Thank you. Thank you so much, Dr. Whitney. And I think